protein diet and gave the rationale for the use of very low protein diet plus supplementations. Of course, all of us know that the goals of diet therapy is to maintain body protein stores, to retard further progression of renal disease, and to prevent build-up of more uremic toxins, and of course, to maintain good nutritional profile for our patients. What are our protein requirements? Of course, this is basically normal patients, not necessarily having a kidney disease. It is supposed to be defined as the minimum intake of protein that balances obligatory nitrogen losses while maintaining energy equilibrium and modest physical activity. Nitrogen balance remains the standard for assessment of dietary protein requirements. Nitrogen balance should be zero, as talked to us by Dr. Refer yesterday. How do we measure nitrogen balance? It is supposedly to establish protein requirements, and this is the current recommendation. And realistic intakes of energy are critically important. For any given intake of nitrogen, supplemental calories will improve nitrogen balance. So we also have to complete for calories aside from protein. In a normal, healthy adult, through many studies, it is assumed that there is supposedly a plateau in the urinary nitrogen excretion within 5 to 7 days after starting protein therapy or diet therapy. Okay? But it may reach 90 days in some studies. So it's not always within 1 week or 2 weeks. Some studies would tell that within 3 months there's still excretion of some amount of nitrogen. These estimates of the requirements of urine from individuals and that nutrient requirements are simply comparable individuals may vary. So each individual may have variable excretion of nitrogen. Thus, safe level of intake has been proposed. What is the safe level of intake of protein? It just signifies protein intake that will meet or exceed the requirements of practically all individuals within the population. And if one takes a particular amount of protein, it will count individual variability. So as we mentioned that there is a variability, but we have to account for the variability, so we decided to give us a safe level of intake of proteins. This of course averages the different studies, the short-term study and the long-term study. And they have found out that the average requirement plus 2 standard deviations should be the requirements of all patients within 2.5% of the standard deviation. In other words, this is the recommendation in numbers. Of course, this came from the 1991 World Health Organization recommendation. It is supposed to be 0.6 grams of protein per kilogram per day. This is the average requirement of protein of high quality. Like for example, eggs, lean meat, 0.6 grams of protein per kilo per day for our patients. And then the safe level of intake should be 25% of the requirement. So about 0.75. You can reach 0.75 grams per kilogram per day of protein. So very easy to remember, 0.6 up to 0.75 grams per kilo per day should be the requirement for our patients in terms of protein intake. What about energy? Of course, energy has to be computed. It is the intake that balances energy expenditure for a specific body size and composition and the level of physical activity. So if you are exercising, you need more energy. An energy intake above or below the requirement will lead to changes in body energy stores, especially your adipose tissues, and it can adversely affect health and function unless compensatory increase in energy expenditure will occur. So the more work you have, the more energy you need. For most of our patients who are in the hospital, of course they need lesser energy because they are in the hospital, but if they are hypercatabolic, they need more energy. That's the reason why the topic for ICU is different, because most of these patients are hypercatabolic. The average requirement without any specific provision for individuality. This is the difference between protein requirement and that of energy requirement. The regulatory mechanisms that have maintained the long-term balance between energy intake and requirements is also a different quality of energy requirement compared to protein requirement. And then, of course, the prescription should be based on measurement of energy expended, and the basal metabolic rate is a predominant component of the energy requirement. Energy expended in aid the body's metabolic processes in the post-absorptive state, while the complete rest is the definition of BMR. This is just an example of BMR is the best available measurement for energy requirements. It varies in body size, composition, and age, and we have also to compute for energy expenditure. This is just an example of how to compute for BMR. You can actually find this in your books or on the internet. But this is just an example that if you're 18 to 30 years old and male, you need to have adjustments of your BMR. Females will have a different value. Older individuals and younger individuals will have a different value. And of course, the best predictor is your weight. Height and surface area do not improve precision of the estimates, and it inversely is related to the actual body weight of the patient. Lighter individuals would have more requirement compared to heavier individuals. And it is believed that consistency and accuracy of these estimates of time spent in various physical activities should be part and parcel of your computation of your BMR. Okay, in chronic kidney disease, what are our nutritional requirements? Chronic kidney disease, of course, doesn't mean that only the nephrologists will be the ones handling patients. Because nowadays, with the KDIGO definition of chronic kidney disease, there are 5 stages. Stage 1 to 5, stage 1, 2, and 3 basically are the normal kind of individuals or patients that ordinary doctors, internists can manage. Stage 4 and 5 basically are patients who may need dialysis or in the pre-dialysis stage. So even if you are an internist, you may encounter patients who are having chronic kidney disease. So you need basically to know what are the nutritional requirements of these patients. Of course, I'm going to talk about requirements in pre-dialysis patients. I'm not going to talk anymore about nutrition requirements of patients on dialysis and those with with acute renal failure. On dialysis, of course, these are basically patients who are being handled by nephrologists, and acute renal failure has been discussed yesterday. So, it is believed that for so many years that restriction of dietary protein